Good evening. I am Brother Dr. Jeffrey Sterling, Surgeon General for Alpha Phi Alpha Fraternity Incorporated, and we thank you for joining us for this evening's Surgeon General Initiative webinar. On behalf of our General President, Brother Willis Lanza III, I thank you for joining us on this incredibly informative topic. We hope that you'll find this stimulating and interesting because in addition to giving you information that you can use, we're going to be giving some perspective on efforts that need to be taken on the national level to eradicate disparities in oral health. Before we begin, I would like to offer my sincerest condolences to the family of and the ladies of Delta Sigma Theta Sorority on the passing of their national president, Cheryl A. Hickman. We know that her legacy is great and will be everlasting, and we wish all the best to her family and to her sorority family. Without further ado, at this point in time, I would like to introduce our Deputy Surgeon General for Dental Health, Brother Langston Smith. And amongst his impeccable credentials, there is nothing that warms my heart as much as saying that he is literally a multiple-time winner of the Alpha Brother of the Year. And I will leave it at that. And I just love this brother and thank you so much for all of your contributions to the fraternity. So Dr. Smith, take it away. Have a great show and I'll see you at the end.
Thank you, Brother Sterling. Good evening, all. I am Brother Langston Smith, Deputy Surgeon General for Dental Health. On behalf of our General President, Brother Lanza III, the Board of Directors, and the Surgeon General, I welcome you to tonight's webinar. Our topic for tonight, Disparity in Oral Health for African Americans. According to the CDC, the nation's oral health has greatly improved since the 1960s, but not all Americans have equal access to this oral health care. NIH reports that too many Americans suffer from diseases of the mouth, with the majority being related to oral health disparity. The report shows that oral health care has not been and is not equitable across America. Our discussion tonight will focus on the disparity in oral health for African Americans. Our distinguished panel will discuss these things with you. But first, please ensure that your devices are muted. And we will have a question and answer session after the presentations. So please place your questions in the comment space and we will try to get them all. Our panel tonight is a very distinguished and acclaimed cadre of dental professionals with outstanding backgrounds in clinical and academic dentistry. I will introduce them alphabetically. Brother Roosevelt Allen. Brother Allen is Vice President and Dental Director of the Government Business Unit, United Concordia. Dr. Allen is a retired Major General of the United States Air Force. He served as the Medical Operations and Research Director and Chief of the Air Force Dental Corps. Brother Allen is a graduate of the Howard University College of Dentistry and completed a comprehensive dentistry residency at Wilford Hall Medical Center. He is a fellow of the American Board of General Dentistry and the American College of Dentistry. Dr. Ken Chance. Dr. Chance is the Dean and Professor of Endodontics at Case Western Reserve School of Dentistry. Dr. Chance completed his undergraduate degree at Fordham University in New York and his dental school at Case Western Reserve. He completed his residency in endodontics at Rutgers. Dr. Chance is the president-elect of the Supreme Chapter of Omicron Kappa Upsilon National Dental Honor Society, and he is a fellow of both the American and International Colleges of Dentistry. Next, Brother Raul Bell. Brother Bell is Professor Emeritus of the College of Dentistry at Howard University. Brother Bell is also a graduate of Howard University's College of Dentistry, and he received his specialty trainings in prosthodontics at The Ohio State University. Brother Bell was a member of the removable prosthodontics faculty at Howard, and he also served as the Associate Dean for Academic Affairs and for Clinical Affairs. His tenure at Howard lasted over 40 years. He is a fellow of the American College of Dentistry. Brother Walter Owens. Brother Owens is the dental director with the Tennessee Dental Quest. He is a native of Nashville, Tennessee, completing his undergraduate work at Tennessee State University. He received his dental training at Howard University, and following a stint in the Army, he began private practice and later became Associate Dean at Meharry College of Dentistry. Dr. Owens is a past president of the National Dental Association, and he is also a fellow of both the American and International Colleges of Dentistry. Welcome, panelists. It's good to have you with us tonight. We will begin our discussion this evening on the topics Disparity and Oral Health with Dr. Allen, followed by Disparity in Dental Education with Dr. Chance, and Disparity in Recruiting Dental Students with Dr. Owens, with a wrap-up of Dr. Bell. So to start us off with the Disparity in Oral Health, Brother Dr. Roosevelt Allen.
Good evening, everyone. Brother Smith, thank you for that introduction. And let me just first say it's quite an honor to be a part of such a distinguished panel. Can we start with the slides, please? As Brother Smith has indicated, I'm going to talk a little bit this afternoon about the disparities in oral health. And as he mentioned earlier, we've seen some significant improvements in oral health since the 1960s. But unfortunately, everyone has not been fortunate to see some of those improvements in oral health. Those individuals, a number of individuals in various groups, have actually seen a decrease in their overall oral health. And the primary reason that they've seen that is because of what's called the social determinants of health. In order to define that, social determinants of health are really those conditions that people are exposed to as a result of where they're born, where they live, where they learn, where they work, and where they play. Those social determinants of health can have a significant impact in a variety of ways. On the right-hand portion of this slides, you will see that some of those factors that contribute to social determinants of health include things like social economic factors, like one's education, whether or not they have a job and the type of job they have, as well as the income that they're receiving. Their physical environment may play a role as well, such as their housing, as well as the availability of urgent and medical care, as well as various schools that are available also. And then health behaviors as well as healthcare also contribute to the social determinants of health. So how does that influence dental health? Well, it plays a role first on whether or not someone can acquire dental insurance, whether they have private or public dental insurance. You know, the type of job that individuals have will play a role as to whether or not they're able to get time off from work so that they can go to some of those appointments. You heard me talk about where people live and the schools that children attend, whether or not there's fluoridated water or whether there's a sealant program that exists for those students. That all plays a role in the type of dental care and health care that individuals receive. And we've heard numerous times about food deserts, how people live in various communities that don't have supermarkets where they can acquire fresh produce and they can acquire the foods that are good for them. So that plays a role as well. And then if we have to look at whether or not there's public transportation. A number of people may not have cars, and so it's difficult to get to those appointments, especially if they're not in the community. So if there are not dental practices or hospitals or facilities that's in the area that can deliver that care, that all will play a role on the care and their overall oral health. So I want to just talk and focus on really sort of three areas when it comes to disparities and the impact that they have. The first I'm going to talk about is really age. And when we talk about age, we're really focusing on three areas. We focus on those children that are between 0 and what we call 20. Those are considered children. Then we look at a population that's 20 above up to like 64. And then lastly, we look at those seniors who are over 65. And all the studies, unfortunately, show that when it comes to age, especially with African Americans as well as Mexican Americans, they have significant disparities that exist. This shows just a subset of those, and a number of studies break these up into subsets. But this is, again, with children from age 3 to 5, as well as ages 6 to 9. They have some of the worst disparities that exist when it comes to healthcare and dental care. One of the reasons for that is primarily because of economics. This slide just shows, if you think about sealants are plastic coatings that are placed on teeth. And those individuals that are in a lower social economic status, they don't have the opportunity to have these sealants placed on their teeth, which help protect them from cavities. On the right-hand side, it sort of shows that, again, there's a 60% increase in those individuals who don't have sealants, that they will end up with cavities on their first molars. If we look at another age group, those individuals who are 35 to 44 years of age, we see the same thing. When it comes to non-Hispanic Blacks, as well as Mexican Americans, they have some of the worst oral health. Some of the worst when it comes to untreated tooth decay that can be seen. What's also concerning is that there are a number of other contributing factors that we also see. While with with non-Hispanic Blacks compared to non-Hispanic whites, we see a greater number of tooth decay. But when you look at again, it comes back to income, as well as if you look at educational level, as well as those who smoke. Those are contributing factors as well that lead to more untreated tooth decay. Now, as we look at, I just want to focus a little bit on the smoking. That is really a significant issue and concern to be aware of. I think all of you are aware that smoking is the primary cause of lung cancer. And so for African-American men, African-American men actually have more lung cancer across the United States than anyone else. So while African-American men are getting lung cancer, it also has an impact on their oral health as well. We see a larger number of individuals who smoke, that they lose their teeth, they have cavities. And again, if you look on the right-hand side, it just shows that 4 in 10 older adults who smoke, they've actually lost all of their teeth. So again, this is just one of the things to be concerned about when it comes to that. And then as we look at those individuals who are over 65 years of age, we see that there is a correlation between severe tooth loss as well as chronic diseases. We know that there's a correlation that exists between one's oral health and one's total health. And we see that those individuals who have diabetes and cardiovascular disease and other health diseases, that there's a correlation with the bacteria and a number of other factors that occur in the oral cavity, and that has an impact on African Americans. The reason that this is very concerning is because when it comes to African Americans and other minorities, especially Hispanics, there's a disproportionate relationship when it comes to many of these diseases. If you look at diabetes, 1 in 6 African Americans will have diabetes in comparison to 1 in 10. If you look at undiagnosed diabetes, it's much larger in the Hispanic population. And then if you look at heart disease, again, a larger percentage of African Americans and other minorities have a higher percentage of these diseases. So again, if you tie that all with dental care, it just leads to a compounding of effects. The other thing I wanted to point out is now if you look at race and ethnicity, again, no matter what you look at, whether you're looking at young children, and this shows roughly 21% of those individuals will have a tendency to have untreated dental disease. And if you look on the right-hand side, it shows the same thing. For those up to 18, you will see in the gray area, African Americans sort of lead the pack. And then if you look at those from 20 to 64, the same thing. You will see a significant number of individuals have disparities associated with just because of their race and their ethnic background. If we talk about education, I think this is important. What we find is that with adults and with all, that based on education, it has an impact on the last time that they were able to visit or they went to the dentist. In essence, the higher educated individuals are, they generally will see a dentist more frequently. This on the left-hand side showed that 54% of individuals who had at least some college education would see a dentist within the last year. This was based in 2016. You can see that there's a significant drop for those who attended high school or did not attend it less than high school. It's roughly about 20%. What is disturbing about this is if you look on the right-hand side, you will see that the individuals who, again, finished high school more so than others are whites as well as Asians. And then those individuals who drop out of high school or don't finish high school, primarily African Americans, Hispanic Americans, and Native Americans. And so again, this plays a role as well on dental care and visiting the dentist. And then you've heard me talk quite a bit about some of the economic factors. This data just shows from really 1967 up into 2017, African Americans as well as Hispanics have been at the bottom when it comes to household income. And so since income plays a significant role on individuals' ability to get in, to be treated, and to receive dental care, you can see why this is a concern. And again, that plays a role on those individuals who do have dental insurance, whether it's private or whether it's public, through Medicare or Medicaid. Those who have it have a tendency to go in and to be seen for dental care, while those who don't, there's a 2.5% times greater that they won't go in to be seen. So how do we address these? I think there are a number of opportunities that we can do as far as closing the gaps. First, support school sealant programs and encourage those in your communities and other communities. Community fluoridation, I think, is important. Stay in school campaigns. I think you've seen the importance of education and how that plays a role. So encouraging people to stay in school. Obviously, tobacco cessation programs, not only cigarettes and cigars and pipes, but also the vaping that's taking place. Encourage individuals to go in for preventive dental visits, and also encourage people that when they're looking at jobs and opportunities to really stress the importance of having benefits, dental benefits, not only for them, but also for their families. And lastly, I think there are opportunities where there can be some policy changes. You've heard quite a bit of discussion with the Biden administration about Medicare, if it should cover dental. I think those are the types of things that can really lead to an improvement in some of the disparities that we're seeing in healthcare and dental care. So I'm going to now pass things on to Dr. Chance, who's going to talk about some of the disparities that we see in education.
I am honored to be here with you on this distinguished panel with this distinguished organization. Could we have the slides at this time? Thank you. This is a slide of our HEC, which is our health education campus in Cleveland, Ohio. And on your left is our dental clinic. And we built that dental clinic in 2019. It's 132,000 square feet. On the right is our Sampson Educational and Administration building. And that was built in 2019 as well. When we look at disparities in education, how do we change a system to better appreciate the participation and contributions of Black people who are traditionally overlooked? One way is to audit that system. And if we were to audit the educational system, we would see that we would be auditing 4 pillars that comprises our mission, which would be teaching, research, clinical care, community outreach and service, and the infrastructure that supports the mission. And that's basically relationships which are political, historical, cultural, financed by individuals, and the selection process of who participates and who doesn't participate, and the policies and protocols that govern these things are all important. We know that there are disparities in dental education. They make our students, faculty of color, staff, and the community feel marginalized, unwelcomed, and isolated. It creates a disincentive for participation in the profession and further success. In the lobby of the Sampson Pavilion, the size of a football field, in fact, the entire building is 455,000 square feet, 80 feet high, and at the cost of $500 million. We look at our school's approach and we base it on the principles and strategies of using inclusion, diversity, equity, and fairness in all appropriate areas of the mission. We pursue this comprehensively and intentionally, led by the leadership at the top. We want to fill the gaps and represent different communities and ideas that have never been heard or seen before. We want to build an educational culture that respects everyone and believe everyone can contribute to this profession, thus increasing a positive environment for our students, faculty, and staff, and representation of color increasing. We want to increase the cultural competencies of our graduates so they are better practitioners, promoting quality dental care in our community. We actively use professionalism, ethics, and scholarship in our encounters, and we take the higher ground. That's an example that was set from our civil rights era, where individuals were prepared, they were poised, and they delivered the message very effectively. The goal is to positively change the lives of those that live in our community. Case Western Reserve University, its president, board of trustees, and leadership strongly supports our Office of Inclusion, Diversity, and Equity, and we have a vice president in its cabinet position. The programs that we have, Diversity 360, that manages and looks at microaggressions, gender identification training, as we address people properly and respectfully, hiring individuals, making sure that the pool is diverse. And if it is not diverse, that particular search is called off. In the lobby of this pavilion, up to 2,000 students are there, designed for people to interact with one another, to leave their egos at the door, and to really look at the multiplicities and complexities of the human body and the human mind, where no one dominates, but all contributes. This building was designed for interprofessional education. Interprofessional education redefines the role of dentistry in general health. This is a partnership between Case Western Reserve University and the Cleveland Clinic. And underneath this roof, it houses 4 schools: our medical school, dental school, nursing school, and the Cleveland Clinic Learner College of Medicine at this State of the Future facility. We want our students, all of our students, to have the competencies that involves respect for others and for other professions, leadership building skills, cultural humility, so they understand the problems that people in underserved communities go through, and they become empathetic towards that. Learning and teaching others between different professions. We've isolated time on Wednesday afternoons to put all of the students together to learn. This particular year, we had them go to community organizations and work on their problems, identified by them, and trying to answer those problems by medical, dental, and nursing students. So they don't go into the community dictating exactly what the community needs, but listen to what the community needs are. We are looking at patient-centered care here, and we are teaching dental students to teach medical students how to provide oral examinations. The use of technology is key in all of this because it reduces the time of instruction and increases the level of understanding and data retention, which allows for expanded curriculum to meet the needs. There's clinical education that involves HoloLens technology, which is an untethered augmented reality processing computer that views anatomy in new and exciting ways. We look at the EPID computerized dental simulation unit, which provides highly interactive dental clinic training in 3D virtual clinic. We're also looking at robotics in our clinics. In the education, we have a strong oral systemic health and clinical combined curriculum, and that is supported by our new National Integrated Dental Board examinations. We know dentists know more about medicine than physicians know about dentistry. We want to change that a little bit. Dentists should know more about medicine, and physicians should know more about dentistry. What we offer is prevention, early detection, behavior modifications in this curriculum. In research, we look at oral health disparities, oral cancer, HIV, and AIDS. We are looking at a business model for dental education, closing the gap between the antiquated dental school training and the practicing community. In the practicing dental community, the use of technology for digital dentistry and same-day dentistry is extraordinarily important. Our community programs are the highlight of what we do at our dental school. We have a Healthy Smiles program where we go into our Cleveland Metropolitan District school system at a cost of $500,000 for us to do sealants and medical education, oral medical education for the students. Also, Safe Smiles, we provide free custom mouth guards for all of the 9 high schools. And many times we find these young people having their first examination meeting us. Our lifelong VAN program, which serves our geriatric patients and provides extended living and nursing home facility treatment. Our dental school is in a highly underserved area, and we want our students to know what that's all about. Very, very important. And expanding our notions of global relations, we have Qasim University in Saudi Arabia and in Future University in Cairo, Egypt. We are training newly minted instructors in Qasim, and we are developing their curriculum in Cairo, Egypt. So there's a lot of similarities between the two, and they need to know the framing of the world. This is not a short-term fix. This is an effort with long-range goals. I believe in the right environment, marginalized people can succeed to the fullest extent of our capabilities, and we're committed to that. I will now introduce Dr. Walter Owens on disparity in recruiting students. Thank you.
Thank you, Dr. Chance. Good evening, everyone. My topic for this evening is recruiting underrepresented minorities into dentistry. Now, I think, are clear, those of us in the dental profession, that there is a crisis in finding underrepresented minorities to be able to work in communities of need. There are roughly 7,200 practicing African-American dentists in this country, and that 41 million African Americans who actually are those individuals who are most in need of care. Now, what is it that we can do? And what is the situation that we face? I practiced for 25 years in an underserved community, and I was the only provider in the zip code for that area. So we had numerous patients, and there's a tendency for African Americans and other minorities to go back into communities that they have a connection with. When we seek health care, we want to be able to trust our providers. Next slide, please. And next, yeah, there you go. When we seek health care, we want to be able to trust our providers and know they understand who we are and our health care needs. When patients don't see people who look like them, when their providers have little understanding of the issues they face, they may feel excluded or unable to get the care they seek. Next slide, please. Now let's look at the picture of it. And the U.S. population, which is roughly 331 million people, and look at it by percentage of dentists for that particular population. Now, whites make up about 61% of the population, and they're 68.3% of the dentists. Asians, who are overrepresented in dentistry, make up 18.7% of all the dentists practicing, but they're only 5.7% of the population. Hispanics make up 18.4%, and they're 7.7% of the practicing dental community. African Americans are 14.2% of the population, but they only represent 3.6% of the practicing dentists in the country. Now, Native Americans represent 3% of the population, but 0.2% of the practicing dentists in this country. Next slide, please. According to the American Dental Education Association, the percentage of blacks in dental school has increased slightly from 5.3% in 2010 to 5.8% in 2019. Now that's 0.5% of an increase in the number of African American students who are going to dental school, while the enrollment of Hispanics has increased from 7.7% to 10% in the same period. Next slide, please. Next slide. Mentoring and recruiting minorities into the dental profession. Minority recruitment is made more difficult by a host of complex social, cultural issues in this target population. Now, our other panel members have alluded to the fact of all the issues that affect these communities, but it also affects our ability to be able to recruit minorities into healthcare. Issues such as crime, incarceration, low self-esteem, low high school graduation rates, health challenges such as HIV, obesity, diabetes, etc., and environmental issues such as substandard housing, unemployment, and a lack of economic resources. Next slide. Without an infusion of young African Americans, Hispanics, and Native Americans into the dental profession, a sustainable access formula will be difficult to accomplish. A report of the Journal of Dental Education found that African American dentists treat a higher percentage of African American patients and a higher percentage of economically disadvantaged patients than do their white counterparts. Next slide, please. You need to go back. The need for diversity in dentistry. The ADIA Senior Survey of Data reported that Black African American students plan practice locations where the major portion of their patients will be from inner city or underserved populations, in a much higher percentage than the white students in that same cadre. The percentage of Black African American students was 68.7% of those who would go back to communities of need and underserved communities, whereas their white counterparts is about 20%. Next slide. Solutions. So what are some of the solutions that we need? The NDA, the National Dental Association Community Pipeline Partnership Initiative, the ADA Ambassador Program, the National Dental Association Mentoring Program, and the SNDA, the Student National Dental Association Impressions Program. For the dental profession, creating meaningful opportunities and incentives to influence young people to take an interest and pursue a career in dentistry is challenging for practicing dentists due to the demands of private practice and a lack of training in mentoring strategies. Next slide. To solve this problem, Harry, Howard, and the National Dental Association have pursued relationships and collaborations with groups and institutions in our communities to identify and motivate prospective candidates through programs such as the Explorer Program, Boys and Girls Scouts of America, Big Brothers, Big Sisters, local school systems, churches, African American fraternities and sororities, colleges, and universities. Next slide, please. Now, the Explorer program, this is one that we had at Meharry. And the Explorer program, for those of you who are not familiar, is an affiliate of the Boy Scouts of America. And for those of us who do have the time to be able to be mentors, we actually need some assistance from these collaborative organizations in order to be able to identify these young people who are prospective candidates. So through our connection with the Explorer program, we were able to identify young people in high school. And actually, this first event that we actually had their parents in as well. And we talk about the opportunities in dentistry and what dentistry is about. And these individuals have been identified by their guidance counselor and schools as being interested in healthcare. Next slide, please. Boys and Girls Clubs of Mentoring Program. Our dental students from the Student National Dental Association partnered with the Boys and Girls Clubs in our area to identify those individuals who have an interest in learning more about healthcare and other areas that they can pursue for success in their lives. What we do, we found out by actually starting a mentoring process with young people as early as elementary school, that we can help develop a vision for them. And through their period of time that they are exposed to it, and through high school and middle school, we can help them to help nurture that vision. And when they proceed to college and to dental school, we can help to support that vision. Next slide, please. This is the Boy Scout Merit Badge Program. Now, for those members in chapters who are looking for ways in order to be able to support young people who have an interest in healthcare and dentistry, our chapter was able to work with the Boy Scouts of America, and they have a dental merit badge program. So these young people with materials that were provided to us by the Boy Scouts, we were able to introduce them, and they can visit dental offices. They visited my office, and we had a chance to show them, and we took them to Meharry. And also, what we also do is we participate and work with them in other programs as well. And that picture to the left shows you a program that we had not only in the dental merit badge program, but also we talked to them about seatbelt safety and other issues to develop survival strategies. Also, with the picture to the right, you can see some of our dental students who were helping with the Boy Scout Merit Badge program. And this was part of our initiative in Go to High School, Go to College. And those individuals on the second row you see in the white t-shirts, white sweatshirts, those were prospective initiates who were interested in being initiated into the fraternity. Next slide, please. Community outreach. We have a program called Lessons in the Lunchbox, where we go into elementary schools along with high schoolers in the area and talk about oral health education to young people. It helps to introduce them to dentistry and dental care, and also it helps them to be able to see people who look like them, so they know that this is something that they can accomplish, and this is a goal they can have a vision for and set their goal in life to be able to pursue careers in dentistry. And so this actual program was started by a Tennessee State graduate, and we passed out lunch boxes to all the elementary kids. The high school students go help to participate and present the program, and they become near-peer mentors for these young people, and they stay with them and help them to develop their interest and vision toward a career in healthcare. And so these are some of the areas that we have worked with in order to be able to identify and recruit minorities and particularly underrepresented minorities into healthcare. I'm going to pass it now on to Brother Rao Bell.
Thank you, Brother Owens. You've heard my colleagues doing an awesome job of stating the issue. And so my job is to kind of tie things together and give you kind of a bird's eye overview of all that they've mentioned and perhaps suggest a few areas of to rectify some of these problems, or at least to address them at any rate. You've heard that we've had a problem, or we do have a problem with access to care. Well, because people of low incomes can't travel easily. They have a little bit of money. And so access to dental care becomes more of a luxury than a normal way of living. We know that groups in rural areas, we know that patients with disabilities, the elderly, all of these groups have specific problems that create barriers for access to dental care. We also know that depending on the job that you have, you may have dental insurance or you may not. Some of the companies who offer dental insurance to employees have practitioners that do not have office spaces anywhere close to where these individuals live. And so if you're an individual who's low income situation, you don't have a car, you can't travel, but the office to which you're assigned because of your union is 20, 30 miles away, there's no way you're going to get there. And so these are the other intrinsic problems, underlying problems that you see that affect one's ability to access dental care. We also have cultural biases where, people of different ethnic groups have different thoughts about dentistry. Many of them think that the older you get, the less teeth you're supposed to have. And so they have no problems having teeth removed and not replaced because they think that's the way of things. And the people who are 70s and 80s should not have any teeth at all. And they're surprised to learn that people do have teeth at 70 and 80, some of them all of their teeth. So these are the things that we have to cope with. Another issue that is in the background is the ethnic distribution of dentists. It is known that Black dentists treat a higher percentage of Black patients and Latino dentists treat a higher percentage of Latino dentists than white dentists do. But there are far more white dentists in the nation. And so this stresses the reason then that we need more dentists. Dr. Chance talks about his dental education, what needs to go on there. He's doing a magnificent job in Cleveland. This needs to be spread all over the nation because we need more dentists and greater ethnic distribution if we're going to approach this problem. We have ethnic groups who have mistrust of government programs. As we know, Blacks in particularly are very wary of government programs based on experience for Tuskegee and sterilization of young women in the South and many other things that this government has done over the period of years. And so that is another problem we've got to surmount. How do we convince the Black population that dentistry is good for them and that we don't want them just to come to experiment on them or to take their money, what little money they do have? So these are the issues that I am seeing as it relates to the overall view of oral health in this country. Behind all of this, of course, is what we call systemic racism. That affects everything in the Black community, in the Latino community, and all the minority communities. We know that there's some majority practitioners who think that Blacks need less pain control measures than they do. And so when minority people say they are in pain, if you're being treated by a majority dentist, the concern may not be as great. And this will not encourage anyone to come back if their pain is not addressed early. And so these overall problems underlie everything that you've heard from my colleagues. So the question is there anything we can do about this? How do we go about trying to even address the issue? Well, I think that there has to be a national thrust on education of dental awareness, and not just once a year or twice a year. It has to be an ongoing program that, in my view, goes from cradle to grave. By the time children are old enough to understand about health, we ought to be teaching them about the importance of dental health, and particularly its relationship to overall health. There are many people who think that all a dentist do basically is drill, bill, and fill and bill. But we know today's dentist does a lot more than that. And this message has to get out to the people so they understand that the dentist doesn't only look at teeth, he looks into the mouth, into the throat. He looks at the face, because that's part of our area we work in the head and neck. And that we can diagnose things, or at least recommend them to go to seek other people for care based on what we do see in the mouth. So it elevates the importance of the dental education. It elevates the importance of visits to the dentist. And most importantly, it elevates the importance of dentistry and dental health in the concept of total body health. Because if your mouth is unhealthy, your body cannot be healthy. But this has to come through education, and it has to be done over and over again from cradle to grave until it becomes an intrinsic part of one's evaluation of health that dentistry is important. Most of our colleagues in the medical area begin their oral examination in the throat, because this is where most of them have been trained. We're finding now that they're also beginning to look into the mouth and to see what's in there, which is a good thing. And so we need to elicit their help in this and have them understand that they can refer patients come to them because of what they see in the mouth, as opposed to what they see in the throat, which is where they begin to start looking at the mouth. We need to improve access to dental care by improving the cadre of practitioners. We need practitioners of all ethnic groups. Dr. Owens talks about the overall percentage of different groups in the country and how many dentists there are based on those groups. And it's obviously a great deficiency because we need more dentists. So therefore, we go back to Brother Chance. We need more education. We need affordable dental care. And unfortunately, Medicaid has not solved the problem because we've got so many dentists now who don't want to take Medicaid anymore, whatever the reason. And so we have a lot of people whose only hope is Medicaid, but the practitioners are not there. And so these are some of the things that I see as an overarching view. We have to get back to education not in high school, but in elementary school, where we stress the importance of science in their education. The STEM subjects. You can't get into dental school or medical school or most of the science schools unless you have a strong background in the STEM subjects. So we've got to go back there, and we've got to educate and educate and educate. I think this is the way we start to address the problem. You cannot solve the problem when you don't know what the problem really is. And most of the people in our population have no idea, one, what dentists really do today, and have no idea of the importance of the dental health to the total body health. And so these are the things that I'm seeing, and I'm cherry picking a bit from Dr. Allen and from Dr. Chance and Dr. Owens to kind of intertwine what they're saying to give an overall view so people get an understanding of the enormity of the problem. This is a problem that cannot be addressed on one front. It has to be addressed on several fronts. And therefore, it is a monstrous challenge to really undertake the improvement of oral health in this country, because we got to deal with sociology, we got to deal with economics, we got to deal with education, sensitivity, cultural sensitivity. We got to deal with systemic racism, and we got to deal with all the things that affect everything else in this country. And so I will wind up by saying I'm very happy to be a part of this panel, because it affords me the opportunity to express what I've learned many years in dentistry, in that solving dental problems is not a matter of just going to the dentist and being treated. A lot of these problems have to do with local government issues, your mayors, your city council people who need to be educated because they themselves do not know, and on and up the chain, so that when dentists come before bodies such as that and speak, there is some empathy and understanding for what the dentist is trying to tell them. And so I will end that by saying, if you ignore your teeth, as we say, they will go away. But if your teeth go away, your overall health also goes away. And so the importance of understanding the relationship of good oral health to good overall body health is the paramount thing that I think that we must educate not only the patients, but those in power as well. I will now pass it on back to Brother Smith to conclude this discussion. Brother Smith. Langston, you're muted, I think.
All right, thank you, Brother Bell. I would like to thank our panelists for sharing this very valuable information that is so relevant to us, and relevant not just to us, but to us, to the country, to our population. So as we move forward, I would now like to ask each panelist to take 1 minute for your final thoughts, starting with Brother Allen.
Well, good evening. Again, I would just like to say, over the last 60 years, we've seen some significant improvements in oral health. A number of people have benefited from those improvements, but there are a significant number of individuals who haven't. And those individuals are primarily African American, Hispanic, and Native Americans. And the reason that is disheartening is because, as Brother Bell and others have mentioned, one's oral health actually has an impact on your overall total health. If you look at a number of the chronic diseases that exist out there, whether you're talking cardiovascular diseases like hypertension, strokes, diabetes, if you talk about some of the chronic respiratory diseases, there is a disproportionate number of African Americans who suffer from these diseases. So if we really want to control these systemic diseases, it also starts with the oral health and the oral diseases as well. And so I think by focusing on that, and by focusing on the social determinants of health on a variety of ways, I think that will allow us to address these issues that exist with a number of individuals across our community. Thank you.
Dr. Chance.
To start with our students, they need to know what conditions lie ahead for them, particularly as they treat African Americans with a long history of being denied. I feel that relationships are all important in doing this, and the inclusion and diversity, equity, and fairness principles should be the foundation of our system of dental education. We must be relentless and unapologetic in removing disparity in dental education. it means too much for us all. Thank you.
Thank you, Dr. Chance. Brother Owens.
Yes, in wrapping up, I think one of the critical points was the fact of recruiting minorities, African American minorities in the healthcare, because we need to provide who is or identify who is the appropriate provider for communities of need, and that there is a critical shortage of African Americans in healthcare in general, and more so even in dentistry. And so our communities need the trusted voices that can be brought to them by those individuals who have an identification with those communities of need. And I think there's something as an organization we can do to support that recruitment of African Americans into healthcare and into dentistry. So I think at some point maybe we need to look more closely at programs that the fraternity can support and institute to help identify individuals in many areas. We have a great crisis with our young people, and then finding a vision that will get them into a positive lifestyle. And so this is one area that we have a great need, and there's a lot of individuals, a lot of young people in our communities who, I said, geniuses who go undiscovered. And there's opportunity to have a good life, an honest life, and a productive life, and to be able to do things in our community to support our community and improve the overall health status and economic status in our community.
Thank you, Brother Owens. Brother Bell, do you have any last wrap up? You covered everything, but I wonder if you might have 1 minute wrap up.
Just a brief comment, Langston, is that I think I can't stress education enough, but not only education of the patients, but education of the officials and the individuals who have the power to make the difference. One of my old professors used to say to me in terms of diagnosis, you only see what you know. If you look at something all day long and you don't know what you're looking at, you'll never recognize it. And I think that our officials need to be educated to the problems that are addressed at lower levels, in addition to informing our patients of the importance of what needs to be done. And I think if you combine the two, then we stand a chance of dealing with this monstrous problem. Thank you.
All right, thank you very much. And now we will turn to our questions and answers. And if you have any questions, please put them in the question section, and I will proceed to ask those as I see them. Right now, I don't see any, but I do have a question, and this goes to any of the panelists. How would expanding Medicare benefits to cover dental care impact dental disparities for those over 65 years of age?
Take a shot at that one, Langston. One thing is that dental care has been a service and a benefit that, for the most part, in a lot of states, is not available. And so, and quite a few of those individuals that in that age range identified, some of them do not even have teeth because they have never had dental care to be able to take care of their oral health needs. And so it's a critical area, it's an overlooked area, and I think it's of a tremendous benefit. And now with some of the Medicare Advantage programs, they are actually growing. And I think there will be an opportunity, and because of the connection between oral health and overall health, I think the quality of life can improve by these programs, by the expansion and of Medicare and Medicare Advantage programs to provide dental services in these communities.
Okay, thank you. This one I'd like to pose to Brother Allen. Are there disparities that exist in military dentistry related to the care personnel receive and promotional opportunities for underrepresented dentists?
So I spent quite a few years in the military, a little over 32 to be honest. And I would say that if you look at the care that is delivered to our members, I don't believe there's any disparity whatsoever. Our mission is really ensuring that the members are ready to deploy and to fight and do what they have to do. And so I don't think when it comes to the delivery of healthcare, there is any disparities. However, I think if you look at the actual number of dentists that are in the military, there are probably some disparities because those individuals that we recruit into the military, they come from our dental schools. And so we see that there are significant disparities in the number of people that are attending dental school when it comes to African Americans and other minorities. And so that carries over as to those candidates that are actually recruited into the military.
Okay.
I think when you see that also, a number of people may not choose to stay around in the military. So as you sort of climb up in the ranks, you see less and less minority representation in those particular jobs or different areas.
Okay, thank you very much. And education is very critical to everything we've talked about tonight. But I'd like to pose this question now to Dr. Chance. What was your most impactful role model as you developed as a dental educator?
I would say hands down, my meeting the late Dr. Jefferson J. Jones, the first endodontics in the state of Ohio. And I met him when I interviewed at Case Western Reserve. And I've never seen a man loom so large in front of my face because I came from Southeast Bronx. And he was critical in having me accepted to Case Western Reserve University. He said to me, I think we'll accept you, but you're a little bit rough around the edges. And I was rough around the edges coming out of Southeast Bronx. But I became a mentee of him, and he poured himself into me and really changed my life. Mentorship is so important and so powerful, particularly when you have a powerful Black man, a successful Black man doing that. To the point where I became a dentist, I became an endodontist like him, I became an academician like him. I named my daughter Jackie like his daughter's name. And I just followed in his large footsteps for all of my professional life. So I know the importance of mentorship and how we need to really increase that with our young people.
Thank you, Dr. Chance. And I might say that I recall Dr. Jefferson Jones because he served as a mentor for me in pursuing my endo boards, my endodontic boards. And he was always encouraging me to get my boards, and then assisted me in preparing for those boards. So I agree with you wholeheartedly. Okay, thank you. There's a question, Jonathan Ward. Are there any over-the-counter advances in oral care that the panel recommends that we should be using? And I'll throw that out to anyone that'd like to tackle it. And I'll read it again. Are there any over-the-counter advances in oral care that the panel recommends that we should be using?
I think I'll take a stab at that, Langston. I think one of the things that, in terms of over-the-counter care, is the electric toothbrush. I am concerned about the other instruments that people sell to pick around the teeth because I think they do more damage to people once they're in the wrong hands. But the electric toothbrush is something that I think has increased the level of oral health because most of them are timed and they make you stay and brush your teeth for at least 2 minutes. Most people with a regular toothbrush will brush, I won't do a lick and a promise. They probably do maybe 15, 20, 30 seconds, clean them out and leave. The electric toothbrushes are timed generally and to each quadrant, and you hear a little buzz, beep, or a buzz. So it makes you brush your teeth longer, and therefore you do a better job. And I think that, to me, is perhaps the best advance they can get over the counter. I am not a fan of the picks and the other things that are available because I think they damage the gums in the untrained hands. But definitely, electric toothbrush is one of the greatest things since sliced bread.
All right, thank you. Is there any input from any of the other panelists?
Yeah, I'm going to concur with Brother Bell on that as well. As part of our programs with DentalQuest, we have many members, patients who have intellectual and developmental disabilities. and that electric toothbrush is of a great aid to them, and also in nursing homes, because when nursing home attendants and care support coordinators go in to try to assist these patients in maintaining their oral health, if they have an electric toothbrush, then they can do a much better job and a more efficient job of oral hygiene than they would by trying to do it manually with the brush. So it makes a significant difference as well. And with the newer ones, you can also pair it with your cell phone to give you feedback on how well you're doing.
Yeah. Okay. Well, thank
Yeah,
you.
one of the things,
Sure.
one of the things that I would focus on also is over-the-counter fluoride. Obviously, a number of times now with cavities, there's a term that if they're not cavitated, you may be able to remineralize that decay. So as individuals are sort of developing the initial lesions that occur with a cavity, if it hasn't broken through the enamel and there's just white spots, there is an opportunity to potentially remineralize that area, and you may not end up having to get a filling. So using over-the-counter fluoride, I think, is also an option.
Okay. Thank you very much. The next question, and this will be our final question. This one comes from Derek Purcell. How does the importance of gut health compare to that of dental health? I'm trying to get that correlation there, but how does the importance of gut health compare to that of dental health?
Well, I'm going to tell you one thing. Good health is important because individuals who do have some gastrointestinal disorders can sometimes have regurgitations. And those can create severe issues with the acid with that regurgitation can create severe issues with the integrity of the teeth. So that's one that hits me right off the bat.
Okay. All right. Thank you, Dr. Owens. Okay. Panelists, Dr. Owens, Dr. Chance, Dr. Allen, Dr. Bell, thank you so very much for sharing this evening with us and really making us more aware, informing us more of the situation dealing with the disparity in oral health. So I'm sure that those of you who have been listening have gained a tremendous amount of knowledge and information. And we just hope that you will share that with others that you come in contact with. And now I will turn it over to our Surgeon General, Brother Dr. Jeffrey Sterling. You're muted, Brother Sterling.
Fantastic job, panelists. I actually am going to hold you over because I have a question that you should have seen coming. In the conversation about disparities, I am endlessly fascinated with the concerns of access to care and quality of care. As a practicing emergency physician, for decades, I have seen patients with oral health complaints come into the emergency department. And although individuals trained in emergency medicine are prepared to treat whatever walks in the door, the acute management of whatever walks in the door, access to a dentist or dental specialist is always the preferred route. Even more importantly, I have had, and again, virtually throughout the specialty, unless you're at an academic institution, which many of you gentlemen are, so maybe you're not as susceptible to these concerns, but in community-based practices, it has proven virtually impossible to send an individual that shows up into an emergency department to follow up with a dentist. In the conversation about establishing the pipeline and having more dentists in our communities and having dentists of color, those are all fine and good. But I'd just like for you guys to address the challenges of once we discover individuals who have difficulties with access to care, and as a result of using the emergency department as their source of primary care, problems with quality of care, what tips can you give people out there who may be listening how to appropriately use the emergency department for dental emergencies and how to use the emergency department to gain access to dentists out in the community?
That's a good question, and I'll take a shot at it. I think, Brother Sterling, you hit on a point that I don't think you realize you hit home. Just as you have physicians in the emergency room, you ought to have dentists in your emergency room, on the emergency room dentist too as well, who understands what is involved. And I think, because our physician colleagues, they have so much other stuff to worry about. Dentistry is on the top of their list, and it shouldn't be. But hospital emergency rooms ought to have emergency dentists also on staff. So, and then that person can do a better job of coping with the emergency. And then they can probably, if there are dental schools in the area, try to make a relationship between the patient and the dental school by maybe setting a pipeline, because dental schools need patients. And if there is a dental school in the area, then that's the first way, because the cost is much less expensive than a private dentist. The dental school benefits, your students benefit, and it's a win-win situation.
So I'll take a stab at that as well. I think first of all, I think there has to be greater interprofessional collaboration. I think there has to be a realization that dentists and physicians have to work together on delivering overall care to individuals.
Indeed.
I think also, as we look in the emergency rooms, I think these emergency rooms need to have a list of community health centers as well as dentists who take Medicaid, because to be honest, most of the people who are reporting to the emergency room for dental care, most of them don't have a dental home. These are individuals who rely solely on the emergency room as a means of getting them out of pain and addressing their dental needs. So again, I think those hospitals need to know where they can send people for free care. And there are a number of facilities that exist that will see individuals based on their income and will provide the dental care they need, but also those dentists in the area that accept Medicare or Medicaid, as well as Brother Bell had indicated, if there are dental schools that are available as well.
So let me give you guys some feedback coming from the other side of the fence. The premise is flawed. I certainly can tell you, I've run 3 trauma centers and have been a medical director at literally 3 dozen emergency departments across the country, all across the country. And what I would tell you, I think an excellent point is made that the audience should be able to understand. An emergency department is different than an emergency room. And if you are a patient that is actually looking for an emergency department that is likely to have an affiliation with a dentist, either on site or as a referral, then you really need to choose carefully when you decide to go to an emergency department. If you go to one of the regional medical centers or a big hospital that's affiliated with an academic institution, you are infinitely more likely to be able to get a referral after your emergency department visit to an affiliated dentist. To any colleagues that may be listening, I certainly agree with the notion that having a panel of all different types of specialists, including a dentist, is a good way to be proactive and to ensure that your patients have access to the services that are needed after the fact. Because if you're waiting in real time to try to find a dentist for follow-up, that's not very likely to occur. I can safely say that less than about 5% of the community-based emergency departments across the country actually have those type of affiliations, largely, as was just mentioned, because of the population of individuals that are using the emergency department as their source of care are not likely to be of the payer class that can get a follow-up within the appropriate amount of time with a dentist. So those are important considerations. But I think that as a broad overview, those that are in leadership positions in hospitals and in dental offices would do very well to simply take the time to forge strategic partnerships and collaborate so that dental care is part of the services that are being offered both in emergency departments, throughout hospitals, and in community facilities. It is really that important. And the failure to do that in the spirit of the conversation we're having leads to ongoing access problems and quality of care problems. So once again, thank you to this fantastic panel. And on behalf of our General President, Brother Willis Langston III, I am Dr. Jeffrey Sterling, Surgeon General for Alpha Phi Alpha. Greatly appreciate you staying with us over time today. And we will see you again in 2 weeks for the next episode of the Surgeon General Initiative Healthcare webinars. Good night. God bless.
Thank you.
Thank you.